Welcome back to the deep dive. Our goal, as always, is to give you that ultimate shortcut through some really dense source material. And today, we are undertaking a pretty critical deep dive into Chapter 37. We're focusing on the pharmacological agents that target the thyroid and parathyroid glands.
A huge topic.
It is. And our mission here is to really structure this for you. We're going to go way beyond just, simple definitions. We want to get into the core hormonal control systems, the drug mechanisms.
And maybe most importantly, the safety warning.
Exactly. The administration protocols and all those essential nursing considerations pulled straight from the textbook.
And it's a unified topic for a reason. I mean, even though they have separate functions, the thyroid for metabolism, parathyroids for calcium, they share this critical goal of homeostasis.
Endocrine homeostasis.
Specifically calcium homeostasis. It's just non-negotiable. If your calcium levels get too out of whack, you're looking at problems with blood coagulation, nerve function, muscle contraction, everything. We have to keep those levels in a super narrow range.
Yeah.
So, okay, let's unpack this, starting with metabolism's master regulator. The thyroid.
Okay, so the thyroid gland, it's this shield-shaped thing wrapped around the trachea, and it's basically the body's gas pedal.
That's a great way to put it.
Structurally, it's all about production and storage. It's built around these things called follicles that hold hormones in a substance called colloid tissue, and it makes two key hormones, thyroxine, which is T4, and triiodothyronine, or T3. And the key ingredient for this whole process is dietary iodine.
No iodine, no hormone production. Simple as that.
Right.
What's really fascinating, though, is the difference between T3 and T4. The body makes way more T4, but T3 is the high-octane stuff. It's about 4 times more active.
Can you give us a way to sort of visualize that relationship? How does that work in the body?
Absolutely. Think of T4 as your long-term bank account. Has a really long half-life, about a week, so it gives you this steady circulating reservoir of hormone. T3 is like the immediate cash withdrawal. It's the active form that actually gets into the cells and revs up metabolism. But its half-life is short, only about 12 hours.
I see. So T4 is the reserve, T3 is the active player.
Exactly. And the key is that most of that circulating T4 gets converted into active T3 right at the tissue level, wherever it's needed.
And this entire thing is governed by that really precise negative feedback loop.
Precisely. It's a classic top-down system. The source material has a great figure on this. Basically, when T3 and T4 levels are low, the hypothalamus releases TRH.
Thyrotropin-releasing hormone.
Right. That tells the pituitary to release TSH, thyroid-stimulating hormone. TSH then tells the thyroid, hey, release T3 and T4. Once those levels rise, they send a signal back up to the hypothalamus and pituitary to, shut it down.
It keeps everything in that perfect, narrow range.
That's the goal.
But what happens when that balance tips? That's where dysfunction comes in. Hypothyroidism, a lack of thyroid hormones, is the most common problem we see.
And the symptoms can be so insidious. Fatigue, feeling cold all the time, just a general slowing down. Sometimes it gets mistaken for just getting older.
Right. And in severe cases, adults can get myxedema. But the really critical one is cretinism in infants.
Absolutely devastating. If it's not treated right at birth, it leads to permanent mental retardation.
Now, before we get to the actual treatments, the replacement therapies, we have to talk about a really dangerous trend that the textbook specifically warns about.
Oh, yes. The use of thyroid hormones for weight loss, for obesity.
So why is that such a huge no-no? I mean, technically, they do increase metabolism, right?
They do, but here's the problem. If you have a normal functioning thyroid and you take this exogenous hormone, you completely disrupt that HPT axis we just talked about.
The hypothalamus-pituitary-thyroid axis.
Right. The high levels of hormone tell your brain to stop making TRH and TSH. Without TSH stimulation, your own thyroid gland it atrophies, it shrinks.
Oh, wow.
So when the patient eventually stops the drug, which they always do, their own gland can't just ramp back up. It leads to this severe, prolonged, and, doctor-induced hypothyroidism.
So the message is pretty clear.
The message is absolute. These drugs are for replacement therapy only, period.
That's a crucial takeaway. Okay, so for genuine hypothyroidism, we use replacement therapy. The prototype drug is levothyroxine.
Yep, synthetic T4. It's the most common because its bioavailability is super predictable. There's also levothyroxine, which is synthetic T3, and a combo called Liatrix.
And administration is everything with these, right? This is usually a lifelong replacement for adults.
It is. And you have to stress to the patient, it's a single daily dose, first thing in the morning before breakfast. And here's the key. with a full glass of water.
And that's not just for hydration.
Not at all. It's to prevent the tablet from getting stuck, which can cause difficulty swallowing or even a serious condition called esophageal atresia. It's a mechanical safety measure.
Got it. And for kids, the dose is actually higher, right?
It is, yeah, based on their weight, because their metabolic rate is just so much higher.
We also have some pretty big drug interactions to watch for.
We do. Cholestyramine can drastically decrease absorption, so you have to take them at least 2 hours apart.
And what about anticoagulants?
These hormones can make oral anticoagulants more effective, which sounds good, but it means you've got a much higher risk of bleeding, so you have to monitor that very closely when you start therapy.
Okay, let's shift gears to the opposite problem, hyperthyroidism.
Right, where you have way too much hormone, often from an autoimmune thing like Graves' disease. This is also where you might see a goiter, that visible swelling of the thyroid gland from overstimulation.
And to treat this, we use anti-thyroid agents, the main class being the thioamides.
That's methimazole and propylthiouracil, or PTU.
So what's their mechanism? How do they work?
They basically work by preventing the thyroid from making new hormones. And PTU has a little extra benefit. It also partially stops T4 from converting to the more active T3 out in the body.
And the textbook has a big safety alert here.
A huge one. The name confusion between PTU and pyranethol. You have to be so careful. Double and triple check the name, because a mix-up could be catastrophic.
Now let's talk about choosing between PTU and methimazole. It's not always straightforward, especially with pregnancy.
No, it's a classic risk-benefit calculation. PTU is generally the go-to for the first trimester of pregnancy because it's less likely to cross the placenta.
Okay, so it's safer for the fetus.
In that respect, yes. However, PTU carries a higher risk of severe liver toxicity for the mother. Methimazole is a bit easier on the liver, but it crosses the placenta more easily.
So the choice really depends on the patient and the specific situation.
Exactly. It's a very careful decision.
And the final agent for hyperthyroidism is less about blocking and more about destruction.
Right. Iodine solutions, specifically sodium iodide I-131. It's radioactive iodine.
It sounds intense.
It is. It destroys the overactive thyroid cells. It's often used for older adults or people who can't have surgery. And the textbook could not be clearer. This is pregnancy category X, absolutely forbidden.
Good to know. And what about side effects?
You have to watch for a condition called iodism. Signs are like a metallic taste, a burning feeling in the mouth, cold symptoms, just general GI distress.
Okay, so we've covered the thyroid. Let's move right behind it to the parathyroid glands.
Yep, these 4 tiny little glands that sit behind the thyroid, and their whole job is regulating calcium. They produce parathormone, or PPH.
And PTH is the main regulator of serum calcium.
The absolute regulator. This is the other half of the chapter's big balancing act. PTH is the calcium elevator. When your serum calcium drops, PTH kicks in.
How does it raise it?
It does 3 things.
Yeah.
It tells osteoclasts to break down bone to release calcium. It increases calcium absorption from your gut. And it tells your kidneys to hold on to more calcium.
But it has a counterbalance.
It does. Calcitonin. And this is interesting. Calcitonin is actually released from cells within the thyroid gland itself.
So the thyroid plays a role in calcium too.
It does. And calcitonin is the calcium blocker. It actively lowers serum calcium, mainly by stopping that bone breakdown process. This whole push-pull system is how we stay in that tiny, life-sustaining calcium window.
So when this balance fails, what kinds of conditions do we see? Beyond just, hypoparathyroidism or hyperparathyroidism.
You see the direct impact on the bones. Take postmenopausal osteoporosis. That's linked to the drop in estrogen. Estrogen normally keeps osteoclasts in check. When it's gone, they go wild and calcium gets pulled from the bone.
I see. And what about Paget disease?
That's a state of just chaotic bone turnover. You have excessive breakdown and disorganized rebuilding, which makes the bones really weak. It all comes back to these mechanisms regulated by PTH and calcitonin.
Okay, so knowing that connection, let's look at the drugs we use to fix these imbalances. When we need to raise calcium, we use anti-hypocalcemic agents.
And the main tool in the toolbox there is vitamin D. The prototype is calcitriol, which is the active form of vitamin D.
And how does that work?
Its main job is to regulate how much calcium and phosphate you absorb from your intestines. It basically makes sure you have the raw materials available to raise your serum levels.
We also have the PTH analogs like teriparatide and abaloparatide.
Right. These are powerful drugs that actually stimulate new bone formation, but they are reserved for really high-risk osteoporosis.
And there's a serious warning that comes with them.
A very serious one. In animal studies, these drugs were linked to osteosarcoma, which is a rare type of bone cancer. Because of that risk, their use is really limited.
So who are they for then?
They're basically a last resort for patients who haven't responded to or can't tolerate the standard first-line treatments.
Which would be the bisphosphonates we're about to discuss.
Exactly. And another key safety point. Don't ever combine these PTH analogs with magnesium-containing antacids. The risk of hypermagnesemia is just too high.
Okay, let's flip to the other side. Anti-hypercalcemic agents, the drugs to lower calcium. The biggest class here is the bisphosphonates.
With alendronate, it's the prototype. Their mechanism of action is to slow down or block bone resorption. They basically put the brakes on the osteoclasts, letting bone density improve.
And this class has one of the most critical, must-know administration protocols in all of pharmacology.
It really does. Every nurse has to know this. For the oral forms, alendronate, risdronate, ibandronate, the patient must take it first thing in the morning when they get up.
With a full glass of water.
A full glass of water, 30 minutes before any other food, drink, or medication.
And the absolute non-negotiable rule.
The patient must stay upright sitting or standing for at least 30 minutes after taking it.
Why is that so important?
If they lie down, the drug can cause severe esophageal erosion and ulcers. It's incredibly dangerous. If a patient cannot promise to stay upright for 30 minutes, they need an IV version instead.
And there's a newer guideline about long-term use, too.
There is. The recommendation now is to limit use to about 5 years because of a small but increased risk of atypical femoral shaft fractures with very long-term use.
Our last drug to lower calcium is calcitonin salmon.
Right, a synthetic version of the hormone. It works just like the natural stuff. Inhibits osteoclasts, lowers serum calcium fairly quickly.
And the big caution here.
You have to screen the patient for a known allergy to salmon or any fish products. That's a hard contraindication.
Okay, let's try to synthesize all of that. Give us the quick recap.
Okay, rapid fire. Hypothyroidism. Its replacement. Think levothyroxine, taken daily with a full glass of water. Hyperthyroidism. It's blocking with thioamides like PTU or destruction with radioactive iodine.
And calcium.
Calcium balance is the push-pull of PTH and calcitonin. Hypocalcemia. You need vitamin D, calcitriol. Hypercalcemia, that's where bisphosphonates come in. And you absolutely must remember the upright rule.
The nursing implications here are just immense. You're monitoring TSH for thyroid therapy. You're monitoring calcium and renal function for the parathyroid agents.
And you're watching the heart. Especially when you start someone on levothyroxine, you have to watch for any new arrhythmias or hypertension because you're suddenly speeding up their whole system.
You know, it really makes you think about the complexity of these glands. How often do you think vague symptoms like, fatigue or hair loss or just feeling slow get written off as just getting older?
All the time.
It really underscores how vital it is to do careful screening, especially in older adults, before just assuming it's age. We have to make sure we're not missing a treatable endocrine disorder.
That is a fantastic point.
And that concludes this week's deep dive into the agents affecting the thyroid and parathyroid glands. Thank you for learning with us, and we really encourage you to integrate these critical safety points into your practice.